Good afternoon. My name is Erica Kime with the National Resource Center on Domestic Violence. Thank you for joining us today, and welcome to this webinar session entitled National Women and Girls HIV/AIDS Awareness Day, Safety Strategies for Women at Risk. This webinar is being hosted by the National Resource Center on Domestic Violence. Promoted by the Office of Women's Health and the U.S. Department of Health and Human Services, National Women and Girls HIV/AIDS Awareness Day is a nationwide observance that sheds light on the disease's impact on women and girls. Every year, on March 10th and throughout the month of March, thousands of people, advocacy organizations, and local and state public health officials host events and share facts about HIV and AIDS. On this webinar, our presenter, Dr. Michele Decker, will discuss the link between dating and domestic violence and women's exposure and risk of HIV, as well as safety strategies for condom use and negotiation, safe disclosure of HIV status, and ways to raise awareness and decrease stigma of this very important issue. Let me tell you a little bit about Dr. Decker. Dr. Michele R. Decker is a trained social epidemiologist with expertise in gender-based violence. She is Associate Professor of Population, Family, and Reproductive Health at the Johns Hopkins Bloomberg School of Public Health, where she also directs the Women's Health and Rights Program of the Center for Public Health and Human Rights. She brings over a decade of research and programmatic experience in gender-based violence prevention and intervention, as well as its impact on sexual health and HIV risk behavior and infection. This work spans both general populations and highly marginalized groups, including homeless, unstably housed, and runaway youth, and those involved in sex trade and trafficking or sexual exploitation. Her work includes the development and evaluation of clinic-based interventions to reduce violence and mitigate its health impact among family planning patients and high-risk women. A community-based model to support survivors of violence, including trafficking at the Thai-Burma border, as well as primary prevention interventions that harness athletic coaches as agents of change to promote equitable gender norms and reduce violence perpetration. So now it's my pleasure to turn it over to Dr. Decker to begin her presentation.
Wonderful. Thank you so much for that wonderful introduction and for having me today as we celebrate this National Awareness Day. It's just a pleasure to bring to this dialogue some of the issues that we see domestically, globally around intimate partner violence and STI and HIV, both for adult women as well as for young women and girls. Can everybody hear me?
Yes, we can hear you.
Wonderful. Great. So we'll go ahead and get started. What we're going to do, let's see here. What we're going to do is just give a very quick overview of HIV and other sexually transmitted infections, STIs, in the United States. We'll talk a little bit about how partner violence creates risk for HIV and other STIs. One really important element to this dialogue is the sex industry, given the issues around both violence and HIV in that area. So we'll talk a little bit about what do violence providers need to know. And then finally, and probably most important for this dialogue, how can advocates support women at risk and those infected? So let's jump right in. As many of you are well aware, women account for about 25% of adults living with an HIV diagnosis and 20% of new HIV infections. So we have about 300,000 women living with HIV in 2013. What's surprising to many is that adolescents and young adults are accounting for the majority of new infections among women. That's true for HIV. It's also true for other STIs. Oftentimes when we're talking about HIV specifically, we always want to keep a broad lens and think about other sexually transmitted infections that are far more prevalent. They are treatable, which is good, but they won't be treated if we don't detect them. So we want to be open, have our eyes open to some of the other issues around violence and other kinds of STIs, chlamydia, gonorrhea. There's a list here, and what we see is that about 60 million women are affected by new and existing STIs in 2013. I didn't include this graph, and I should have, is really just an emphasis on the young adult and adolescent populations are accounting for the majority of new sexually transmitted infections in the United States. And they're also, as we know, a really important population when we're thinking about partner violence and dating violence. Our data from the CDC overwhelmingly tell us that the age at onset, if you will, is truly in that adolescent to young adult age range for partner violence. So as we're thinking about youth issues in particular, that synergy, that interrelationship between partner violence and STI and HIV is really very, very potent for our youngest, the youngest people that we are working with. So I just want to give you a couple of graphs illustrating sort of the burden of HIV based on experiences of partner violence. These are some recent data from the United States showing that that those that have experienced physical or sexual partner violence are much more likely to have been diagnosed with with HIV specifically, HIV/AIDS. And then we see the same patterns in other places in the world. This is one example from a very large study in India looking at HIV infection based on experiences of partner violence. So you can see there's about a threefold difference in that risk of infection, right? The prevalence is relatively low as it is in the United States in terms of the HIV burden specifically, but that disparity tells us that there's something really going on in terms of partner violence and HIV. And finally, some data from back to the United States and that adolescent population is looking at the Youth Risk Behavior Survey, which, as many of us know, is a leading, really our best means of surveillance on many health issues for adolescents in the United States, a school-based survey. And this is a graph that is really telling us the difference in STI or HIV diagnosis based on experiences of partner violence. So you can see, even in this adolescent population, that about 9% of those who had experienced physical or sexual dating violence also reported an STI or HIV diagnosis. And that was compared to just 3% of those that had not been exposed to violence. So again, these graphs are just illustrating a couple of examples of a very large research base that links partner violence with STI, HIV risk behavior, condom non-use, multiple sexual partners, as well as infection. I've given you a couple of those references there. I should note much of this research is cross-sectional, so we don't really know a lot about the causation from a lot of this research, and that's been a real question in the field. And what I want to tell you is that increasingly in prospective research, where we're studying people over time, we're seeing that partner violence is indeed associated with incident STI, including HIV. So what does that mean? We're seeing increasingly that we can link temporally in time experiences of partner violence with new infections, STI and HIV. And that has been done here in the United States, as well as a variety of other places in Africa, as well as India, and those are a couple of references there. So that's strengthening our knowledge base in terms of the causal pathways linking violence with STI and HIV. And as we're thinking with our advocate hats on, with our provider hats on, we want to really make sure people are aware about the added risk for STI and HIV that comes with partner violence, and we'll talk about how and why that happens. Finally, I'll note we've also seen in where it's been studied really more frequent and also more severe partner violence among HIV-infected women. So what are some of the reasons for this, right? STI and HIV, sexually transmitted infections, requires contact with an infected individual, right? So why on earth are we seeing these patterns? Well, we see in situations of partner violence certainly compromised sexual negotiations. So women that are unable to refuse sex or certain kinds of sex. Anal sex is increasingly important to this dialogue, and we'll talk a little bit more about that in greater detail. But as many of you are aware, anal sex has an incredible transmission efficiency, right? An incredible risk of transmitting the infection relative to vaginal sex. So this is a really important piece for us to bring into the dialogue with our clients. Certainly coerced and forced sex is usually unprotected. And of course, this can also result in physical trauma, right? So this can additionally potentially facilitate transmission. Compromised condom negotiation is a really important piece. Condoms are obviously our frontline HIV prevention for heterosexual or same-sex transmission, right? So in situations where individuals are unable to ensure that condom use, where perpetrators of violence are refusing condoms and removing condoms, we see that breakdown of defense against STI and HIV, and that's a big piece of this. And finally, one thing that is perhaps not always part of this discussion, but really should be, is what we see actually is greater risk that's introduced by male violence perpetrators. So violence perpetrators, and I'll show you some of this research, engage in greater sexual risk behavior. That means they're also more likely to be infected, and I'll show you some of that data as well. So even in situations where there's not sexual violence or sexual coercion, simply being involved with a violence perpetrator may actually be a marker for sex with somebody that is more likely to be infected. So I wanted to give you a couple of examples from some of our qualitative work. This is an adolescent describing condom refusal that led to an STD. She's telling, I told him to put on a condom and he didn't. I went to a clinic and they said, oh, we gave you chlamydia. She confronted her partner and he said, it wasn't that it was me messing around with someone else. And she says, that's not true. I was like, you were the only guy that I was with. So not only did she get an STD as a result of this unprotected sex, in the end, this person is blaming her for introducing the infection and using that again to perpetuate this violence. Another example, this led to this situation of condom refusal led to both pregnancy and STD for this adolescent woman. She's telling he would never listen. She says, don't you think you should wear condoms? I might get pregnant. And she's telling, he's telling, next time. She's telling, I'm scared. I'm really scared. I feel like he's going to hurt me. I don't know. I just feel like he's going to hurt me. So obviously some real challenges in ensuring condom use in a situation like this. Why is this so important? For pregnancy prevention, we have intrauterine devices. We have emergency contraception. We have some methods of preventing unwanted pregnancy that are not reliant on partner involvement. Unfortunately, when it comes to STD and HIV prevention, we are still really reliant on condoms, be they male condoms, be they female condoms. Just to give you a little bit of an illustration of some of these coercive condom dynamics and how we see them in partner violence relationships, these are some recent data from family planning clinic studies, and we see that women reporting recent partner violence are reporting much more condom non-use against her will. Those are the women in the red here. Interestingly, those that are not in partner violence situations are also reporting a lot of condom non-use against her will. So there's a sense there that there are some dynamics that extend beyond partner violence situations. But women in violent relationships are much more afraid of asking for a condom in the middle there, and then they're much more afraid, certainly, to refuse sex. And you can see that disparity pretty clearly. So we want to come back to anal intercourse. This is truly an unappreciated HIV risk factor. It has been historically, particularly when we think about heterosexual relationships. Again, there's a real transmission efficiency with anal intercourse that we need to be aware of and become very comfortable talking about this with our patients. In part because we also see that partner violence is associated with anal intercourse, right? This isn't distributed evenly in the population. Rather, we see consistently over a variety of studies you can see here that partner violence situations are dovetailing with anal intercourse, often unprotected. And much in the way that we see for vaginal sex, abrasions and lacerations that accompany unwanted sex, again, can facilitate transmission. This is just a graph illustrating the differences in engagement in recent anal intercourse, and unprotected anal intercourse based on partner violence experiences. And so both of these graphs are showing us that those in partner violence relationships are much more likely to engage in recent anal sex and unprotected anal sex. So again, affirming that this is something that really needs to be part of this discussion. Just to come back to this point on perpetrator risk, just to share with you some of the data on this, male perpetrators of abuse engage in greater sexual risk behavior. So what does that mean? Sexual infidelity, concurrent partnerships, injection drug use, anal intercourse with male and female partners, coercive condom non-use, and sex with high-risk partners, so women that are involved in sex work and a variety of other elements. So these abuse perpetrators are more likely to be infected. And I'll show you on the next graph. We had an opportunity to really look at this in a large study in India. We matched husband-wife dyads and actually found that couples where women were reporting partner violence, the men in those couples were much more likely to be HIV infected. So this makes partner violence a risk marker for being with somebody that is HIV infected. Does this vary across settings? Absolutely. But this is telling us that those partners are a really important piece of the puzzle, particularly when we're thinking about infectious disease. So pulling this all together, how does partner violence relate to HIV and to STI? Well, we see that women that are victimized by partner violence really face this quote-unquote double jeopardy, right? High-risk male partners are more likely to be infected. So again, partner violence is a risk marker for an infected partner. And above and beyond that, the limited control over sex and other aspects of violence relationships may facilitate transmission. So again, thinking about those elements of condom coercion, coercion for higher risk sex, these may actually facilitate transmission in the presence of infection. So moving on, now that we know about some of the patterning of partner violence and STI HIV, where does that take us? Well, violence is also an issue when we're thinking about disclosure. So unfortunately, as you saw from some of the quotes as well, STI and HIV disclosure can be a trigger or a context for abuse. And fear of partner violence, we know as well, can be a barrier for women seeking health care. So these are some of the reasons that we really need to be addressing this synergy, and really with a need to prioritize safety both in accessing testing as well as treatment and related health care. I'll show you a little graph on this as well. Here we see that partner violence survivors are more likely to fear notifying a partner about a potential sexually transmitted infection. So why is this so important? Partner notification is really a cornerstone of infectious disease control, right, for STI as well as for HIV. One of the recommendations, and we'll talk about how to facilitate safe disclosure, but knowing this and knowing that those women that are involved in partner violence situations may be really afraid to make that disclosure, there's a real need to help women reconcile those two pieces, help them find ways to disclose safely or anonymously. The evidence around violence in response to disclosure is mixed. There are certainly reports in some places where, again, disclosure of an STI or HIV has been a context for violence. This is an example where we didn't see this in this particular study, so be aware that it's a possibility in terms of violence being sort of an outcome potentially of partner notification. So I want to, before we get into sort of what to do from the advocate and program perspective, I want to just again raise this issue of violence in sex trade or the sex industry, and why do that on National Women's and Girls HIV Awareness Day? Why do that in the context of IPV, partner violence, domestic violence, or dating violence? Well, partner violence and other forms of abuse are very common among women involved in the sex trade. and we use that term broadly. It includes sexual exploitation. It includes economically motivated sex. How does this happen? Abusive partners can pressure women into sex trade as a means of control or obtaining scarce resources. We see women becoming involved in sex trade as a means of escaping abusive relationships, or when they find themselves out on the street without a lot of resources with nowhere to go. Sex trade is certainly a way of getting by for many women. And we also see that pimp relationships can begin as or be presented as romantic relationships, right? We see that women who wind up in pimp relationships that they ultimately describe as such will say, oh, he was my boyfriend. Oh, it started out as my boyfriend, or it evolved in that way. And we also know, this is very challenging, I think, from a service delivery standpoint, is that many women that are involved in sex trade, trafficking, sexual exploitation, we'll get into some of the nuances there, may also present those partners, those pimps, as boyfriends, right? Oh, he's just my boyfriend. Oh, this is my date kind of thing. And really that term is masking a much more complex dynamic that we need to be aware of, or we will miss it. Why is this so important in terms of the topic of the day, in terms of HIV? Obviously, it's because women involved in the sex industry in any way consistently demonstrate very high rates of HIV and other STIs. So a recent global analysis showed that it was about 11 times that of women of reproductive age. So that's fairly staggering, right? We've historically thought about this population as a vector for disease transmission. But in more recent years, there's been a real recognition of some of the gender-based vulnerabilities within this context. What does that mean? Trafficking as a way of entering the sex industry, violence victimization from partners, clients, pimps once involved, and certainly, again, coercion and limitations on power to negotiate sex and condom use. I would like to show this slide at the very top. I don't know if you can see it. It says, what's in a name? And you'll see a variety of different terms that are used to describe the sex industry. We won't spend a lot of time here. You can see there's a real variety: sex trade, transactional sex, survival sex, trafficking. What's common among these is really that behavioral element, the exchange of sex for drugs, money, or other resources. What's distinct, or what's assumed to be distinct, are degrees of agency, exploitation, and control. So maybe at one end you've got a highly controlled situation, a highly pimp-involved situation where women are not having any control or agency at all, and maybe at the very opposite end of that spectrum, you've got people that are very willingly engaged, trying to make some extra money, et cetera, and you don't have a worry for coercion or exploitation in that context. The realities are that a lot of the assumptions that we assign to these words have not been well tested. Many that are involved in sex trade don't identify as sex workers, they don't identify as trafficking victims, they don't identify as prostitutes, et cetera. They're trying to get by, right? And we really, truly don't know very much about the conditions of entry, ability to exit, all of these dimensions of agency. We have a very robust literature on quote-unquote female sex workers without a lot of knowledge as to the level of control that they have in those situations. So just a word of caution as you're taking a look at that literature and trying to reconcile some of what we see and hear, both on the topic of violence as well as HIV. So what does this mean for advocates? Sex trade is a context for intense HIV risk, multiple sexual partners, often unprotected, elements of violence and control from a variety of perpetrators. Being sensitive and just aware of the possibility that partner violence can co-occur with sex trade or sexual exploitation for your clients is really important. Again, women that are involved in the sex industry in any way are very accustomed to flying below the radar, right? They go in for services at a variety of places. This is something that is so stigmatized. They're very accustomed to sort of hiding some of these elements, and we will miss it if we're not attentive to it. Certainly establishing relationships with programs in your area that work with women in sex work or sexual exploitation so that you're in a good position to make that referral should you identify somebody in need of those services. And really, again, anticipating some of the unique dimensions of shame and trauma for women involved in the sex industry. shame around being involved in the sex industry, even when it is coerced or against their will, and certainly when it's not as well. These are elements that undermine women's ability to access our services. They think oftentimes that the help that's available to women in the general population does not apply for women, quote unquote, in the game, in the life. And in truth, our services, be they domestic violence, be they rape crisis services, in truth, they really, many people can benefit from those that have been in traumatic situations. So coming back to sort of this broader topic of partner violence and HIV, what are some of the implications here? I want to really sort of delve into this in terms of raising awareness. This is one of our primary roles as advocates and as providers, is simply raising awareness about some of the links between violence and STI and HIV, reminding clients that abusers engage in greater risk behavior, asking them, have they been tested, supporting them and seeking that testing if they haven't done so if they need to. We're often working with women that have immediate crisis needs, and so it can be hard to prioritize this. Make sure that you work it in your dialogue when you're trying to hit on some of the non-urgent needs. This is a real key element of health and health promotion for women. So we can leverage some of these data that I've shared today to just generate discussions about sexual negotiation, condom negotiation, anal sex, and these obviously can be framed in a context of safety and health, right? So this isn't something that is tangential to our goals of safety and health for women. Rather, it's very much part and parcel of those goals. So raising the issue of sexual violence and coercion, giving clients an opportunity to raise these issues, affirming that their experiences are common, are not unusual, right? We can do that through some of our normalizing probes. People are going to have different comfort levels or different ways of communicating some of this. And I encourage you to work with your colleagues to think through how can you work this into discussion, right? So asking questions around sexual decision-making. How much do you feel you can refuse sex? Is sexual violence ever part of this? Is sexual coercion ever part of the picture for you, right? Condom coercion. Well, what does condom negotiation look like? How much do you feel that you have a say in protection? Some of these questions are going to lead into dialogue about coercive elements of sexual or condom decision-making or coercion that may otherwise be missed. And it's important for us to help our clients have those aha moments of this coercion is actually maybe part and parcel of the abuse that I'm experiencing, helping them integrate their health and safety with experiences of partner violence. Anal intercourse. I think this is a real challenge for us. This isn't something that we've always necessarily been comfortable talking about. You know, it's sometimes sensitive to talk about sex with our clients at all, and then getting into various, sexual practices, et cetera, can be sensitive, certainly. I've just given a couple of examples here. One is just, we're hearing a lot about violence and unwanted anal sex, so we're starting to ask about that, right? Getting that on the table, putting it on the table so that people can tell us, oh my gosh, how did you know? Or maybe it's not an issue for them, and that's fine too, but we want to make people aware of this, right? We want to plant those seeds, whether they're comfortable sharing or discussing that in the moment, or maybe it's going to take them some time to feel comfortable opening up about this. We know that sexual violence in particular is an area that many of our clients have a real deep shame about, and so what we want to do for them is open that dialogue up, give them an opportunity to escape from that shame by putting it on the table, by helping them through those dialogues. So really importantly, what can I do to support testing, right? So it's really ensuring access to testing for clients. Some of us are lucky enough to have on-site medical facilities at our shelter and our programs. Many of us are not, right? So if you don't have on-site testing, make those connections with providers and find out not only where are the testing sites in your area, and I've given you the CDC link here, but make sure you find out how sensitive are they to issues of violence, what kinds of outreach and education are you going to need to do to to help people manage some of this, and really make sure that you feel confident referring patients or providing that in-person advocacy to make sure that your survivors are treated with respect and so forth at these STD programs. So supporting safety and testing, this is a big one, particularly for people who are going to be providing that advocacy on site at STD or HIV programs. The best defense, again, is preparation. So safety planning with women for a potential diagnosis. What is that going to mean for the partner? How are we going to do partner notification, right? Become familiar with some of the partner notification protocols in your area, and this varies from place to place. Sometimes there are opportunities or mechanisms in place for anonymous notification at the county level, at the city level. Clinics, depending on what their capacity is, can oftentimes do a clinic-facilitated notification. These are things that can enhance safety for your patients. You can also enable safety through anonymous disclosure. There's a fantastic website program that I've included here, sotheyknknow.org, and that's a mechanism for anonymous disclosure, sending an anonymous email to partners that may have been exposed allows that obligation of partner notification of a diagnosis without the safety, without some of the safety repercussions there. Again, a clinician or an advocate-supported referral, and certainly safety planning specific to disclosure. Many of our STD providers are aware of some of the safety issues. Many of them are not. So this is an opportunity to raise awareness in that clinical context of some of the needs around patient safety, particularly for partner violence survivors. Why is this so relevant to an STD program? Again, thinking back to that data, we've seen very clearly in the U.S. and many global contexts that there's a real relationship between partner violence and STI and HIV. So our STD programs and our HIV programs, whether they know it or not, and many of them do, a lot of that patient population is exposed to violence. So this is not irrelevant to their goals either. I want to talk a little bit about PEP, post-exposure prophylaxis for HIV. This is essentially, many people have heard of this, I'm sure, an antiretroviral therapy program that can reduce risk for HIV after exposure. This is often, certainly an incredibly important part of sexual violence response, in part because it's really used within up to 72 hours of exposure. So it has limited utility for people with frequent recurring exposure, such as people that are in long-standing partner violence situations. But I do want to make people aware of this if they're not already, because it is important in terms of a standard package for sexual assault providers. Oftentimes, and it varies, this can be covered by insurance or access through Office of for Victims of Crime. So these are things to explore in your states and municipalities if you haven't already. Really very important, particularly when we're thinking about the sexual violence response team. So just a couple of notes on supporting HIV-positive women for those of us that are working in shelter programs or in ongoing care situations where we know that many of our survivors are likely to be HIV infected, or maybe we even know that they are. Obviously, helping to prevent violence and abuse much in the way that we do for any of our patients. Providing a safe and supportive environment for disclosure, should they choose, right? We don't want to pressure anybody for a disclosure, but we do want to make sure people know that this is an area that we can be supportive in. Considering issues in terms of medication adherence and access to medical services. We'll talk a little bit about that. As well as certainly using universal precautions when we're handling any bodily fluids, simply to reduce stigma. We want to make sure, the whole point of universal precautions, the whole point of policies in this area is to make sure that nobody is feeling singled out because of an implication about their HIV status or because of knowledge about their HIV status. So obviously handling any bodily fluids as potentially infected. Being aware of any other associated issues, particularly around partner interference in medication, et cetera, and creating a service support network. So what does that mean? Reaching out to positive networks in your areas, making sure that you have a clear referral or program in place for making sure you can connect women with ongoing HIV support services if they need it. And also really making yourself available, not that you don't all have plenty on your plates, but making sure that those programs in your areas also know that about your expertise in the area of partner violence support. Okay. So again, just around violence and HIV status disclosure, we talked a little bit. Violence can certainly result from disclosure of HIV status. And what we're increasingly seeing as well is that abusers can use women's infection status as a tactic of abuse and coercion, much like they can use many other things. We're only too familiar with this. But certainly as a threat, right, to reveal a status to family or friends or employers, to influence parental custody decisions, humiliation or degradation for being infected, and using that status as an excuse for violence or abuse. These are some of the unique dimensions that HIV brings into the picture when we're talking about partner violence. Again, providing that safe and supportive environment for infected women, assuring confidentiality as we do in any aspect of the care that we provide. But again, using that non-stigmatizing, non-judgmental language and actions. You, and I should say we, are an important part of changing the culture that stigmatizes HIV-positive women, right? So we want to own that, and we want to make sure that we're not perpetuating that stigma, we're changing that. So talking about HIV the way you would about anything else, reminding staff and other clients, using this as a teachable moment about how is HIV transmitted, right? And really demonstrating that we're not afraid of becoming infected, right? Our care is for anyone that comes through our doors. Again, we've talked a little bit about this just in terms of access to health care. I'm really just emphasizing this because I want to really make people aware that one of the main things we can provide is advocacy and support in accessing care, right? So partner violence can be a barrier for infected women accessing care. Again, that fear of violence as a disclosure can prevent women from seeking care and testing. And certainly we see that abusive partners are preventing women from accessing care. Threats of violence, isolation, stalking, interference in the medication. So helping women overcome that barrier to care, and health care in particular is a big part of our role. And as I've mentioned, partner violence and interference in medication adherence. So for those of you that don't know, HIV medication regimens can be very complex, and adherence is critical. And yet we know that adherence can be really challenging for women in violent relationships that have the disruption, certainly element of it, shifting from house to house, shifting to shelter. All of these things can be just incredibly disruptive. And we also see that partners may directly interfere in some of this medication as an element of control. So we want to be aware of this. And we also know, of course, that women can have a real hard time consistently taking these medications, giving some competing priorities. Other aspects of partner violence, other outgrowths of partner violence in terms of mental health, PTSD, and depression, these are actually associated with low adherence. And these are many of the things that we're grappling with in our shelter and our programs. So seeing that synergy come together is just to really emphasize one of the things that we can really do is help women stay on those regimens, help them prioritize their safety in the face of all that they are going through is a real step forward and something that we can really do to support infected women. So bringing this all together, again, this is raising awareness of the links of violence with STI and HIV for all of our clients, right? For shelter when we're doing outreach and education, and certainly in shelter situations. Initiating discussion with our clients about the STI and HIV risks that can accompany partner violence, especially some of these sensitive elements of sexual negotiation, condom negotiation. Give people an opportunity to raise those issues, and you'll be surprised at how common this is in your patient populations. Assuring access to testing is absolutely key, and making those connections with providers, knowing where those testing sites are, making sure that there's the advocacy in place to help people through that process in a way that's not stigmatizing in any way, and recognizes some of the safety issues around disclosure, right? So hop on that website, SoTheyCanKnow.org, get familiar with some of the other options for STD disclosure. Those are ways that we can really empower our patients. And I think I'm going to end there and just open up for questions. I've included just a couple of resources. These are largely from the academic literature, but for people that are interested in following up on any of these references and getting a little bit of a broader sense. And I think I'm going to stop there because I'm sure people have questions.
Okay, great. Thank you so much, Michele. Right now, I only have one question that's popped up in the chat area. I'll encourage anyone that's on the line right now, if you have any questions, to feel free to type that into the public chat area, and we'll get them asked. So the first question that we have is, what is involved in universal precautions?
Yep, great question. Great question. CDC has some great guidance on this, and let me pull up, so this is essentially, I was going to try to pull up the CDC page. So anyway, this is handling all bodily fluids as though there's a risk of infection, right? So what does that mean? Rubber gloves for any handling of bodily fluids. Let me just see if I can pull up that wonderful CDC page for this. I can get that out to the group. There's a set of these universal precautions, and they really dictate how to handle any kind of medical emergency, and also things that are non-emergent but could put you in contact with bodily fluids. So a minor cut, right? Making sure, so what are the precautions? They're handling all of these bodily fluids in a way that assumes that they're all infected, right? We don't want to take the risk that someone's infected and we're just not aware of it, one. And two, we want to make sure that we're not treating certain people differently. We're not, I'm going to touch one person's blood but not someone else's blood, right? And so these universal precautions make it such that we're not in a risk, we're not putting ourselves or our staff at risk for infection, nor are we at risk for stigmatizing any one individual because we're giving an impression that their blood is safe or unsafe. But again, let me get that CDC website out to you so you can see it all laid out. It's just an incredibly helpful resource.
Okay, great, thank you.
And I see you've already done that. Fantastic.
One of our colleagues put that link in the chat area, so feel free to copy and paste that into your browser to visit that page. So I'm not showing any more questions. It is a small group, so there might not be any more questions. So I guess we're going to end here. Michele, if you have any closing comments you'd like to?
No, I don't think so. It's great to get a chance to share all this. I hope you learned something, and I hope that it's helpful to you in your work. Thank you.